and welcome to the Binding Sites webinar on MGUS, serum-free light chains, and renal biopsies, an innovative approach to uncover plasma cell dyscrasias. Our guest speaker today is Dr. Guillermo Herrera. Dr. Herrera is an internationally renowned nephropathologist with over 30 years of experience in renal pathology. Having received his Doctor of Medicine at the University of Puerto Rico, he has over 25 years of basic research on renal damage. He has served as professor and chairman of the Department of Pathology at both St. Louis University and Louisiana State University, Shreveport. Dr. Herrera sits on multiple national panels and has been the invited guest lecturer in over 260 domestic and international venues. He has authored more than 120 articles and chapters in renal pathology. As an expert in renal damage and plasma cell dyscrasias, Dr. Herrera is the editor of a book titled The Kidney in Plasma Cell Dyscrasias, a comprehensive state-of-the-art view on the subject, published by Carter in 2007. He is also the editor of the book Experimental Models for Renal Diseases, Pathogenesis and Diagnosis, published by Carter in 2011. Dr. Herrera has acquired international prominence as a result of his innovative studies in the field of renal amyloidosis. His research interests also include the effects of monoclonal light chains on the kidney and immunolabeling at the ultrastructural level. Dr. Herrera is a member of multiple professional societies, including the American Society of Nephrology, the International Society of Nephrology, and the United States Canadian Academy of Pathology. He is currently the president of the Renal Pathology Society, an international organization with more than 400 members. Dr. Herrera has received the Tatiana Tientovich MD Award from the Armed Forces Institute of Pathology, American Registry of Pathology, for contributions to renal pathology. From the University of South Alabama Health Sciences Center, he has received the Distinguished Scientist Award for contributions to science. Dr. Herrera, it is our pleasure to have you here today, and I will now turn it over to you.
Thank you very much for your very kind introduction. It is a very exciting topic indeed, the one that we're going to address today, which, as you heard, is going to be monoclonal gammopathies of unknown significance, which from now on I will refer to as MGUS, serum-free light chains, and renal biopsies. And what I'm going to try to show you is how the renal biopsies can actually uncover plasma cell dyscrasias that are not even suspected at the time the biopsy is done. I will try to start very basic and move on into the subject. And it's important to remember that each one of the kidneys contains approximately 1 million nephrons, and that the kidneys are extremely vascular organs which receive up to 25% of the cardiac output, which makes sense then to understand that circulating light and heavy chains will reach the kidney, will reach the glomeruli, and eventually some of them will produce damage. Approximately 85% of the light chains in patients with plasma cell dyscrasia will be associated with nephrotoxicity. And all this occurs because there are a clone or clones of neoplastic plasma cells which are producing this physicochemically abnormal light and heavy chains. Today we're going to focus primarily on light chains and the kidney, not so much touch the topic of heavy chains and the kidney, which is a bit different in some ways. So the light chains go into the circulation. They're produced by neoplastic plasma cells, and they reach the glomerular capillaries. Because the light chains are low molecular weight, they will go into the capillary walls and get filtered through the capillary walls into the urinary space, and they will then reach the proximal tubules. And it is in the proximal tubules where the normal light chains will be metabolized. And what will happen is that this low molecular weight protein, of which light chains are an example, will go to the proximal tubules, they will be reabsorbed, and the endosomal system, which is going to be very close to the apical portion of the tubule, will take those light chains in and destroy them. That occurs when the light chains are normal. And that will, of course, release amino acids, which will go back to the circulation. If you pay attention to the right side of the screen, you will see an ultrastructural label section of kidney at the EM level. And what we have here is these gold particles are labeling kappa light chains, and you can see them being absorbed through a very specific system, which is the so-called receptor megalin tubulin, which is located in the microvillus border of the proximal tubule. And these light chains get absorbed into the tubule, and here you have the endosomal compartment intaking those light chains and eventually destroying them. This is what happens with normal light chains. So they come in through the blood, they get reabsorbed, and amino acids are delivered to the circulation. And this picture here illustrates the same process that I show you at the ultrastructural level, but now we're using immunohistochemical stain for kappa light chains, and notice that everything that is happening in the apical portion of the proximal tubule. Nothing is happening anywhere beyond. Once we start dealing with the structurally abnormal light chains, things are different. If we were to look at this in an schematic way, the light chains interact with the megalin-tubulin receptor. They get internalized, the endosomes take them in, they destroy them, and the receptors go back to the surface. That's what happens normally. Now let's talk a little bit about light chain pathobiology. What is interesting is that the damage that occurs in the kidney, it occurs because those light chains are abnormal. And they can be in various quantities. There are patients that secrete very small amounts of very toxic light chains to the kidneys, and there are others that produce large amounts of toxic light chains. Anyhow, we know that there is an underlying clone of plasma cells responsible for the production of the light chains, and when these nephrotoxic light chains produce damage in the kidney, in 70% of the cases, the damage is going to occur in the tubular interstitial compartment. And in 30% of the cases, it will occur in the glomerular compartment. So the pathology would be different, and we will see that in a minute. On the other hand, and I'm just going to make this comment about heavy chains. When you have circulating heavy chains, they are almost ever associated with tubulopathic effects. They just produce damage in the glomerulum. And so the reason why light chains are producing the damage in the kidney is because they are structurally abnormal in their variable portion. Changes in the variable portion of the light chain is what makes them nephrotoxic, what makes them attracted to various compartments in the kidney and produce pathology. So it is also the conformation of those light chains what allows them to interact with various receptors in various places in the kidney and eventually produce damage. So the structure of that light chain, which is physicochemically abnormal, the conformation of that particular light chain secreted by that patient with a plasma cell dyscrasia, that is responsible for the damage in the kidney. And as I told you before, the damage can occur in the glomerular compartment or in the tubular compartment. In the two diseases that characterize the damage in the glomerular compartment are the deposition diseases of light chain deposition disease and the AL or light chain associated amyloid. And the ones that produce damage in the tubular compartment, they will produce the damage either in the proximal tubule or in the distal tubule. Now let's keep in mind that there may be combinations of these things. You can have a patient with light chain deposition disease and also an obstructive phenomenon in the distal nephron, such as Cass nephropathy. And so those combinations can occur, but we're going to try to dissect them differently and separately so that our understanding can occur better. And don't ever forget that behind all this, there's a clone of malignant plasma cells producing the damage. And so we can identify the deposition of monoclonal light chains in the kidney and immediately conclude that this patient has a plasma cell dyscrasia that may not have been uncovered before the renal biopsy. In renal biopsies, as you all know, not only we do the regular light microscopy sections, but we routinely do electron microscopy and immunofluorescence. And those two techniques are extremely important for us when we're assessing kidneys from patients with possible plasma cell dyscrasia, because information will be obtained from those two techniques that is absolutely essential for a definitive diagnosis. Now let's go to the serum-free light chains and look at the International Myeloma Working Group guidelines. It is said to be of use in the diagnosis of plasma cell dyscrasias, and the inclusion of free serum light chains, along with the serum protein electrophoresis when screening, will increase the ability that you have to detect these plasma cell dyscrasias. And also in the setting of renal insufficiency, even though there is increase of both kappa and lambda light chains, the ratio of these two light chains is usually maintained normal. So we're going to be looking at the relationship of free kappa to free lambda light chain, and that ratio will become extremely important, and you'll see how this plays a role in the evaluation of renal biopsies in one moment. Keep in mind that we're going to emphasize the role of serum-free light chains in screening and detection of undiagnosed plasma cell dyscrasia, but also in the evaluation of patients who have had a diagnosis of MGUS for various periods of time. I would say that in my renal practice today, it is not uncommon every day to get one case, at least, of a patient that comes in and has a biopsy because this patient has MGUS and some sort of renal dysfunction. Let's also keep in mind that when patients are on dialysis, the situation becomes a bit more difficult, And then you need to be able to take that ratio that we normally consider normal and expand it a bit to really make sense of an abnormal ratio. And it is up to 3.17, the kappa to lambda ratio. When it's more than 3.17, that's definitely abnormal, even in a patient on dialysis, and that patient needs to be assessed accordingly. If that patient has renal disease, it is possible that that renal disease be related to a circulating nephrotoxic light chain. These are the 5 things that can happen in a kidney in a patient who has an underlying plasma cell dyscrasia. I want to go through some of this with more detail than others, simply because I think it's important to understand the nomenclature. I want to make sure that we make better the interaction between pathologists and clinicians, and that clinicians understand what it is that we're talking about as we speak about these different types of damage in the kidney. The first 3 that you see there, the so-called proximal tubulopathy, and the second one, which is simul tubulopathy with intracytoplasmic, those 2 are very similar. The only difference between one and the other is that in one we will find some characteristic intracytoplasmic inclusions in the proximal tubules. Keep in mind that in both cases the target of damage is the proximal tubule. The acute tubular interstitial nephritis pattern mimics to a key a tubular interstitial nephritis, and frankly the pathologist can identify the process, but he or she needs to and associate that process with deposition of monotypical light chains to be able to say this is due to an underlying plasma cell dyscrasia. All these processes, number 1, 2, and 3, are based in the proximal tubules. The 4th is light chain myeloma Cas nephropathy, which is probably the best known entity associated with a patient who has an underlying plasma cell dyscrasia. And that particular pathology is localized to the distal tubule, where the distal tubule gets clogged and obstructed with light chains that interact with Tam-Horsfall protein. And then the last 2 entities are entities that preferentially develop disease in the glomeruli, and that includes the light and heavy chain deposition diseases and the light and heavy chain amyloidosis. That is not to say, of course, that you have depositions in light and heavy chain deposition disease, also in the tubular interstitial compartment and also in the vascular compartment, the same thing with amyloidosis. But the main place where the activity is taking place is in the glomerulus, and it is first in the mesangium. So having said this, let's just go through some of these patterns in detail. But before I do that, let me give you an idea of how often these things happen. A recent study that I have conducted of 3,300 renal biopsies, about 4% of these patients had some kind of renal manifestation of an underlying plasma cell dyscrasia. Of those, 2.6 had manifestations that were either based in the glomeruli preferentially, meaning deposition disease or amyloid, or they had Cas nephropathy. So those are definitely the most common manifestations that we will see. But 1.3% of the total number of patients did have some of the manifestations that I mentioned that are centered in the proximal tubule, which we need to talk about more because those are new entities and entities that not everybody understands today. The first case that I want to show you is a very interesting case of a 60-year-old hypertensive female who had had an MGUS for 10 years, and she has had progressive renal insufficiency. The serum creatinine has increased from 1 to 3.5 in the last 10 months, and she has really no proteinuria and no hematuria. The UPEP was negative, and the bone marrow biopsy had only 5% of plasma cells and had been declared as no evidence of plasma cell dyscrasia. Interestingly, 3 light chains in the serum. The kappa to lambda ratio was 60, which indicated to the nephrologist that something was not right and that the renal biopsy was very much indicated. And when the biopsy was done, we found some damage due to vascular disease, but the most important damage was located in the proximal tubules, where there was basically tubular necrosis. And this is an important concept because the tubular necrosis can be very overt, very simple for the pathologist to identify, or it can be very subtle. And the key is to relate that tubular damage to the presence of monotypical light chains. And so we call this entity tubular proximal tubulopathy. And it can be quite dramatic, as you can see in that picture, where the tubules are totally destroyed and the actual tubule no longer appears like a tubule. But remember that there are many causes of acute tubular necrosis. If a pathologist renders a diagnosis of acute tubular necrosis in this section, he or she is correct. But the key here is to identify that that is related to an undiagnosed plasma cell dyscrasia. Back in the 1980s, Dr. Sanders and myself at the University of Alabama in Birmingham were perfusing rat nephrons with human light chains. And we identified that lesion back then when we were perfusing certain light chains. We saw changes in the proximal tubules that were identical to the ones I have shown you. It took about 30 years for this to be translated into human pathology and be appreciated as a specific entity. This is an example of what we saw in those nephrons that we perfused. We saw damage to the proximal tubule with apical bleeding and numerous lysosomes, which here, again, using the technique of ultrastructural immunolabeling, are packed full with monoclonal kappa light chains. And so what was happening here is that the light chain was being internalized, and these lysosomes were trying to destroy it, but in the process they were not able to do that. They were releasing their contents, and they were producing damage in the tubules. And this was the end result that we would see in some of those tubules where you have vacuolization and damage to the proximal tubules as a result of the endosomal and lysosomal contents being released outside and destroying the tubule, the cytoplasm of the tubules. Notice that it's not only in the apical surfaces as it happens in normal light chains, but now the action has taken over the entire tubule where the damage has occurred. This was a patient back then in the 80s, which was quite fascinating to me because I made a diagnosis of acute tubular necrosis, and we were not doing routine kappa lambda light chains at the time. And so I diagnosed it as acute tubular necrosis. The nephrologist gave me a call and said, you know, this patient has lambda light chains in the urine. Is it possible that the lambda light chains be related to this patient's acute tubular necrosis? I found myself an antibody to lambda light chains, and you can see what's happening in the proximal tubules. The cytoplasm of the proximal tubules is full of kappa light chains, of lambda light chains. And of course, the staining for kappa was totally negative. And when we did the ultrastructural labeling, we saw all the lysosomes. The proximal tubule was full of lysosomes and contained large amounts of monoclonal lambda light chains. So the acute tubular damage was due to the actual action of the lysosomes on the physicochemically abnormal lambda light chains. And so let's see what happens actually in this case. In this case, the light chain is endocytosed, just like any light chain. The lysosomes, endosomes, and the rest of the lysosomal system come to the rescue to try to destroy the light chain. They can't. They burst, and they release their contents, and they produce damage to the proximal tubular cells, mimicking what you would see in acute tubular necrosis. And so the pathophysiology associated with this is very clear. We have a physicochemically abnormal light chain that is endocytosed through the usual tubulin-myelin receptor mechanism. The endosomes cannot handle it. They recruit the rest of the lysosomes to help them. They still cannot do it, and eventually they break up, burst, and release their enzymes, and they destroy the cytoplasm of the proximal tubular cells. When that happens, there are also a number of inflammatory and pro-inflammatory components that get released, and so some of these cases may have variable associated inflammation. There's one variant of this, which I call the constipated lysosomal type. In this type, you have the proximal tubule, which is completely packed full of lysosomes, which have different shapes, they have different sizes, and it's as if these lysosomes can't deal with the light chain that is being endocytosed, to the point where they don't burst, they just get weighted there. Interesting enough, these patients present with Fanconi syndrome. They have inability to absorb glucose, they have inability to absorb phosphate or amino acids, so they have phosphaturia, glucosuria, and aminoaciduria. And that's why it's called the constipated lysosomal type. A rare type, not seen very often, but seen sometimes. Let's see what happens in that situation. The light chain gets internalized, the endosomes try to handle it, they can, they recruit the rest of the lysosomes, they enlarge, they get atypical, and look what happens. The entire proximal tubule gets constipated with lysosomes of various sizes full of the monotypical light chain. So what do we need to remember about proximal tubulopathy? We need to remember that there are different flavors of it. Some of these patients present acutely in acute renal failure, some present in slowly progressive renal failure. And some of them have a Fanconi-like syndrome, like the so-called constipated lysosomal type of damage that we just showed, and we're going to see another one in a minute. But the full recovery is possible because the tubular regeneration is so capable of bringing those tubules back to normal, but of course you need to go ahead and repair or try to eliminate the delivery of those light chains to the tubules so they have time to regenerate. It is an extremely poorly recognized pattern. It is a pattern that is starting to be recognized by pathologists, but realize that there are still difficulties in recognizing it because you have to be very careful in associating the light microscopy with the immunofluorescence, and I would say also with the electron microscopy. The correlation of light microscopy, immunofluorescence, and EM is absolutely essential. And recently, there have been, in the last few years, a couple of papers that have shown the importance of this particular pattern of damage. I want to share with you case number 2, which is also a very exciting case. It's a 70-year-old female who has diabetes mellitus, hypertension, dyslipidemia, nephrotic range proteinuria, MGUS for 25 years, and chronic renal disease with progressive increase in serum creatinine from normal baseline level of 1 in the last 3 years to 3.3. Now, this patient has 1,000 reasons to be able to have the renal damage, but when the serum free light chain kappa to lambda ratio showed up to be 3.7, that was kind of, what should we do here? Is it possible that the renal disease related to this patient, MGUS, that has had for 25 years? And a renal biopsy was done. And what was interesting about this biopsy is that the patient did have some evidence of diabetes, did have some diabetic glomerular changes, and those were responsible for the proteinuria that she had. But she also had a very peculiar finding in the proximal tubules, where there were empty spaces, almost angulated, almost like there was something there that we couldn't see, kind of a subtle pattern, and those were found only in the proximal tubules. And so this is the type in which you have proximal tubular damage associated with typical monoclonal inclusions. Almost all these patients are kappa light chain related, and this particular section here shows the presence of the crystalline inclusions stained for kappa light chains, and I thank Dr. Markowitz for this particular slide, which is so nicely shows the pattern of damage in the proximal tubules. Realize that this is not seen in every case that clearly, and that the immunofluorescence in some cases can be negative. And one of the things we need to do is a pronase digestion, as I will mention in a minute, to be able to bring out those inclusions. And that's how they look in the proximal tubular cytoplasm. These inclusions have electron-dense appearance. They look almost crystalline, as you can see here. And in this particular case, I have labeled them using the same gold technique, and you can see how they are labeled for kappa light chains. And as I said, the great majority of these cases, with very few exceptions, are kappa light chain related. The crystals can be rhomboidal, as you can see here. They can be rectangular. They can be different sizes. That is very characteristic of this particular entity. If we were to look at it in a schematized fashion, same thing. The light chain comes in, endosomes try to deal with it, but you know what? They can't. And then they start having this production of this crystalline-like inclusions, as you can see here, which then populate the cytoplasm. And that kind of picture is just characteristic of this particular type of damage in the proximal tubule. This happens seldom. This is not as common as the other patterns that I have shown to you. So we call this proximal tubulopathy with inclusions in tubular cells. Now, sometimes this is a very insidious disease. Very slow deterioration of renal function. There's one case in the literature that it took 30 years for the patient to manifest really clinically, but generally it happens a little faster. The diagnosis of an underlying plasma cell dyscrasia can be very difficult because usually the clone of plasma cells is very small, but it does have some pathognomonic ultrastructural findings, as I show you. And as I mentioned to you, the regular immunofluorescence may be negative, and you may need to do a pronase digestion to be able to bring out these classical inclusions. There is an animal model which is available, created by Chirac and co-workers in France, that can be used for testing pharmacologic interventions. This is one entity that has very specific light chain specificity, which means only certain light chains are associated with this pattern of disease, this pattern of pathology. And they are almost invariably kappa light chain associated. Most are of the BK1 group, and there are two germline genes that are usually associated with this, which are the IGKV1, 33, and 39. The reason in this is that this particular light chains have a peculiarity of the variable kappa domain, where there are hydrophobic residues at position 30. When that occurs, there is resistance to proteolysis by the lysosomes and propensity to form crystals. And therefore, that's the pathology that we see in these patients. A variation are patients who have another subtype, BK3 subgroup, encoded by L2, L16, or L16, where no crystallization occurs, and that mimics more the proximal tubulopathy that I showed you before without crystalline inclusions. And that brings me to case number 3. This is a 76-year-old male with diabetes mellitus again, hypertension, anemia, trace hematuria, and acute renal failure. The serum creatinine is 6.82, and the SPEP is negative. The UPEP is questionable. There is a very small monoclonal spike that nobody was willing to say that it was indeed an important one. and the serum free light chain kappa to lambda ratio was 5, obviously abnormal. Bone marrow biopsy showed 3% plasma cells. No typing of the plasma cells was performed. In this particular case, what was found was an inflammatory process in the interstitium associated with tubulitis and tubular damage, something that looked just like an acute tubular interstitial nephritis. In fact, many of the inflammatory cells were eosinophils. So if you were to look at this and stop there, you would call this acute tubular interstitial nephritis with eosinophilia. You would think of a drug that the patient may be taking, and that's not the case, because you're able to demonstrate that there is an underlying monoclonal light chain deposit associated with the process. Then you know what you're really dealing with. Just to show it a little bit better, this is a PAS stain section where the tubular basement membranes are highlighted, and you can see the inflammatory cells breaking through the tubular basement membrane and producing what we call tubulitis. Now, this can be all over the biopsy, or it can be localized to very small areas of the biopsy. So again, you need to carefully evaluate these cases in order to make the diagnosis. The clincher is to demonstrate that together with that process, there is monoclonal deposition of either kappa or lambda light chains. The majority of these patients are also kappa light chain. And here you can see how surrounding each one of the basement membranes, there is linear deposition of kappa light chains. Now, this can be focal in the biopsy, depending where the inflammatory process is located, or it could be all throughout the biopsy. Of course, the stain for lambda light chains would be entirely negative. Or you could do immunohistochemical staining using paraffin-embedded tissue. This doesn't work all the time, but in this case, you can see the beauty, how beautiful it is, the deposition of kappa light chains along the tubular basement membrane associated with this inflammatory process. The clincher is to demonstrate monoclonality associated with this inflammatory interstitial process. If you look at your ultrastructure carefully, you may find this deposition of kind of punctate electron-dense material along the tubular basement membranes, as you can see here. In this case, we have immunolabeled that material with kappa light chains. And that corresponds to the immunofluorescence staining that you saw in the previous slide. This is rather frequent. In fact, I say this is the most common pattern that I see today associated with interstitial damage in patients with plasma cell dyscrasia. This is a pattern that you can recognize, make a diagnosis, and tell the nephrologist, look for the plasma cell dyscrasia because it is there. And it's something that is very important. I emphasize there are no tubular casts present. Usually kappa, but lambda light chain can be seen, and you have to have a high index of suspicion to be able to identify this process as being related to an underlying plasma cell dyscrasia. So how is this happen? Well, again, the light chain gets reabsorbed. The endosomes try to handle it. They can't quite do it. They carry the light chain all the way to the end of the tubule, to this part of the to the part of the tubule, and then they deposit the light chains on the outside of the tubule, on the outer side where the basement membrane is. When these light chains reach that location, that elicits an inflammatory reaction, a release of cytokines, and so you have the inflammatory type of tubular interstitial nephritis associated with monoclonal light chain deposition. These patients usually have a pretty fast deterioration of function, and again, this is the kind of situation where you have to have a high index of suspicion so you can make the correct diagnosis. And again, correlating your light microscopic with your immunofluorescence with your electron microscopy findings is extremely important. Back in 2006, we published the first paper alluding to this entity, and we proposed that transcytosis, as I show you, was the main mechanism involved in getting the light chains to the opposite side of the tubule and creating the inflammatory reaction, although it's possible that there may be also some passive tissue diffusion from peritubular capillaries reaching the basement membrane of the tubules. Whatever it is, the point here is the light chains are carried from the apical surface to the opposite surface and deposited on the basement membrane side, eliciting an inflammatory reaction. A few words about light chain cast nephropathy. This is what myeloma kidney is. Myeloma kidney is not all the others I mentioned before. This entity is the one that's called myeloma kidney, simply because years ago, when people had myeloma and renal disease, everybody thought everybody had cast nephropathy, and that's just one of the varieties of disease that you can find in these patients. And of course, the classical presentation is the presence of multiple casts, primarily located in the medulla, although you may see them in the cortex as well. And these casts have what we call fractured planes, as you can see here, and they have an inflammatory reaction which surrounds the cast, as you can see here, and this inflammatory reaction can be variable, and that's associated with inflammation and edema in the surrounding tissues. Now, that is a classical case, and not every case is like that. Sometimes you see a multinucleated giant cell reaction associated with the cast in the tubules, as you can see here, and all that gives you clue that you may be dealing with a case of myeloma or light chain cast nephropathy. Of course, the reason this happens is because the certain light chains with certain physicochemical characteristics have a tendency to interact with Sam-Horsfall protein, and then they form this cast in the distal nephrons preferentially, and sometimes extending to the proximal nephrons as well. This is a stain for Sam-Horsfall protein, and the point is the Sam-Horsfall protein colocalizes with a particular light chain producing the myeloma cast nephropathy. In a minority of cases, perhaps 1 to 3% of patients with myeloma cast nephropathy, instead of seeing the cast that you saw before, you see crystalline casts. In other words, casts that are characterized by crystals, as you can see here. When you see that, you know what you got, especially if you can prove monoclonality. But that doesn't happen but in a minority of the cases. Dr. Sanders has done incredible work in demonstrating the interaction between Sam-Horsfall protein and certain physicochemically abnormal light chains in producing this entity. And he has found that the interacting domain of the kappa and lambda light chains is in the CD3 region. And there are numbers that have been published showing why this is and how this happens. Again, it used to be said that if you took a series of patients with plasma cell dyscrasia and renal disease, the majority of the patients had this entity, light chain cast nephropathy. Interestingly, the more current series are showing that the majority of the patients have AL amyloid. So it seems like we're being more aggressive in biopsying patients with proteinuria, and then we uncover the underlying plasma cell dyscrasia. And partly, we're doing kappa and lambda light chain staining in every case, and we're after trying to make the correct diagnosis. It's interesting that acute renal failure is the most common presentation in myeloma cast nephropathy, but not the only clinical presentation. There are some patients that lose their function slower and come in with a more chronic type of process. Again, it may be the clinical presentation of myeloma. So the pathologist may look at the biopsy and say, does this patient has myeloma? He or she can ask the nephrologist, and the answer may be, no, we don't know that. Well, you can make the diagnosis of myeloma by looking at the sections. Now, like everything else in life, you need to prove that those casts are associated with monoclonality, and that doesn't happen in every case. And that can create some problems. And one pitfall is a patient with acute tubular interstitial nephritis with very rapid, severe acute renal failure, rapid renal deterioration, that has casts that can look just like casts in myeloma cast nephropathy. They still will stain for both light chains, although they may have more of one than the other, and that has been described in the literature in patients taking rifampin, tacrolimus, rapamycin, and so forth. So keep in mind that sometimes the pathologist cannot be absolutely sure that he or she is dealing with cast nephropathy, but may suggest it because the findings are suggestive of that. And what happens in those cases is a trapping of the non-relevant light chain in the cast. And that happens typically in the more chronic cases. If you have acute deterioration and acute obstruction of the distal nephron, you tend to have only the pertinent light chain. And that takes me to the last case, case number 4. And I bring this case to illustrate another point, which is also very important. But let's get into the case. 45-year-old male who has hypertension and mild proteinuria, about 500 milligrams per day, and has an IgG monoclonal gammopathy on SPEP. The serum creatinine is 2.5. The bone marrow biopsy has 26% plasma cells, lambda predominant. So here the issue of is it not, is not there. It's clearly that this patient has a plasma cell dyscrasia. The serum ratio was inverted with more lambda than kappa light chains, twice as much lambda than kappa. And the question that is raised here is, what lesion do you think you will find in the renal biopsy? Now let's recapitulate. Patient has mild proteinuria and has an elevated serum creatinine. So that's the clinical picture, and your question is, what would the lesion be? And the point I'm trying to carry across is that the renal biopsy can sometimes uncover a lesion that you are perhaps not suspecting. One of the things I would suspect in a patient like this is perhaps a tubular interstitial manifestation of a plasma cell dyscrasia. But when the biopsy was done, we identified the presence of amyloid in the vasculature, not in the glomeruli. This is a Congo red stain, typical some pink staining, as you can see here. But in the glomeruli, there is no amyloid, just in the vasculature. And this is a close-up of the Congo red stain. Of course, you need to polarize that stain and demonstrate the typical apple green birefringence to make the definitive diagnosis. And that carries me to the last area that I want to discuss, and that's amyloidosis. One of the problems with amyloid is that the complaints of the patient are very nonspecific, and most times when I make a diagnosis of AL amyloid, there is no suspicion of an underlying plasma cell dyscrasia. When I call the clinician like I did this morning, and I say the patient has amyloid, but not only amyloid, but the patient has lambda amyloid, which means the patient has an underlying plasma cell dyscrasia, I normally get, oh, we didn't have a clue that that was going on. So again, the renal biopsy can be the way to diagnose and uncover a plasma cell dyscrasia. The diagnosis can be very simple, but it can be quite difficult. In this particular case, which was one that I faced a few years ago, there were 1 of 12 glomeruli with expanded mesangial areas such as you see here, nothing really dramatic, just very focal, and that area stained with Congo red, polarized apple green, and also ultrastructurally was shown to have the typical fibrils of amyloid. Fortunately, most of the time it's much easier. This particular glomerulus here is completely architecturally altered as a result of deposition of eosinophilic amorphous material, as you can see here, in the mesangium and extending to the peripheral capillary walls. That material is Congo red positive, and when you polarize it, it creates the typical apple green birefringence, which is so characteristic of amyloid and diagnostic of amyloid. I use thioflavin T stain very often in making the diagnosis of amyloid because it allows me to detect very small amounts of amyloid that the Congo red stain sometimes does not pick up. Thioflavin T stains are easy to read, easy to perform, and they can very nicely show, by showing fluorescence of the amyloid, the fact that the patient has amyloidosis. And of course, the gold standard is the ultrastructure of this material, which is typically fibrillary. The fibrils are randomly distributed. They measure somewhere between 7 to 12 nanometers in diameter. Once you have that, you have amyloid. The pathogenesis of amyloidosis is fascinating. I don't have time to get into it, but I just want to make 1 point or 2 points. First point is that there are receptors on the mesangial cells that are selective for certain nephrotoxic light chains, as we like to call them, glomerulopathic light chains. Those receptors are shared by light chains that characteristically produce deposition disease and amyloid. They're shared, same receptor. But what's interesting about amyloid is that it's internalized into the mesangial cell, and again, the endosomes try to destroy the light chain. They are unable to. They recruit the lysosomal compartment. They transport the light chains all the way to the mature lysosome, and it is in the mature lysosome where the amyloid is formed and eventually extruded into the outside of the cell. It's a very interesting process which has many steps, and you can think pharmacologically how you could affect each one of these steps to prevent the formation of amyloid in the kidney. And I think that's the future of the treatment of this disease. Now, amyloid can be associated with 30-plus different proteins. And not every amyloid, of course, is AL amyloid associated with kappa or lambda light chains. And, of course, most of the light chain-associated amyloid is lambda, and most of the amyloid in the kidney is lambda 6. But there are many, many other proteins that can be associated with amyloid, and it is the role of the pathologist who makes a diagnosis of amyloid, be it in the kidney or in any side of the body, to typify that amyloid. And what we're looking for is which one is that fiber protein that is associated with the amyloid that is being deposited. Normally, we do a battery of 9 stains in our renal biopsies, and that battery of 9 stains will test for the presence of heavy chains associated with the amyloid and light chains associated with the amyloid. That will take care of our AL and AH, or amyloid related to heavy chains. In most cases, there are some physicochemically abnormal light chains and heavy chains that because of their abnormality, because of their truncated nature, they cannot be detected with the polyclonal commercially available antibodies. So if you have a negative stain for kappa, lambda, and heavy chain, does not necessarily rule out a case of AH or AL amyloid. But I would say that in the majority of cases, you'll be able to pick it up by doing those stains. We also do a fibrinogen stain that will pick up the very rare alpha-fibrinogen amyloidosis. So our regular group of stains that we have allows to pick up all those types of amyloid. And then we have stains, immunohistochemical stains, that will allow us to pick up other amyloids such as AA protein-associated amyloid, beta-2 microglobulin amyloid, calcitonin, transthyretin, lactoferrin, lysozyme, and so on. But that requires specific stains to do that. The difficulty in identifying the amyloid related to plasma cell dyscrasia lies in the how abnormal is that physical chemical light chain and whether it can be picked up with our antibodies. Now, in a study that was done and published in the American Journal of Surgical Pathology in 2006, 92% of the type of the amyloids could be typified, but I don't think it's as good as it sounds. Some of the results here were by excluding other types of amyloid, not necessarily by detecting the specific type. However, there is a new technique, the mass spectroscopy, which you can use to detect the type of amyloid. So you have amyloid, you want to know the type. You can actually go to the tissue in a paraffin block, take out tissue from there, put it through the mass spec, and be able to characterize the type of amyloid. Requires very small amounts of amyloid, the equivalent of the amyloid present in 1 glomerulus, and only a couple of centers, however, are doing this today. And it's costly, and it may not be necessarily something that the insurance company will pay for it. But if you're not able to typify the amyloid on your routine fluorescent staining of kidneys, this is a way to typify an amyloid. And sometimes we recommend to do this. And also remember, there could be 2 different types of amyloid deposited in the kidney. If you have that kind of situation, I think the best way to go is definitely mass spectroscopy. And this may be the future for amyloid typing. Again, remember that the clinical presentation of these patients is usually atypical because amyloid can be located in any organ, and sometimes it's very non-specific. And many times, as I said at the beginning of this discussion, it is the renal pathologist, the one who makes the diagnosis of an underlying plasma cell dyscrasia associated with amyloid. Remember that the typification of amyloid is the standard of care, and also that early amyloidosis can be easily missed. And a point about heavy chain amyloidosis, it is definitely underdiagnosed. There are less than 50 cases reported. We're missing heavy chain amyloid today. In conclusion, I would like to make a few points. There's no question that our understanding of how kidney damage occurs in dysproteinemias has expanded considerably in the last 2 decades, markedly improving our diagnostic capabilities. It is one of those situations where we have been able to take from the research lab to the diagnostic arena information that has been useful to improve our diagnostic capabilities. Also keep in mind that light chain variability preferentially accounts for the involvement of different renal compartments, for the patterns of renal damage that I have shared with you today, but keep in mind that there are also some host and certain other pertinent factors in some instances that may be important as well, as it is, for example, in cases of myeloma Cas nephropathy and dehydration. A patient who is dehydrated has more propensity to develop light chain Cas nephropathy. Serum-free light chain testing has improved considerably our ability to screen for plasma cell dyscrasias and to be able to do the proper testing to make a final test. Finally, renal biopsy may provide unequivocal evidence of the presence of an underlying plasma cell dyscrasia or uncover end organ damage in a patient with MGUS when other diagnostic techniques may not be able to do so. Thank you.
Thank you very much, Dr. Herrera. Audience, the session is now open for questions. You may ask a question by typing it into the question and answer box located on your GoToWebinar window. Our first question is it the abnormality of light chains produced in multiple myeloma and AL amyloidosis, or just the sheer number of these proteins that is responsible for most of the damage to the kidney?
The light chains that are associated with damage in the kidney are obviously physicochemically abnormal light chains. And it is the structure of those light chains, the conformation of those light chains that varies from normality, what makes them produce damage in the kidney. And actually, there is relationship between the kind of structural abnormality that we see and the damage that is observed. And of course, the most classical example of that are those light chains associated with the crystalline inclusions in the proximal tubules, which, by the way, I forgot to say, those patients clinically manifest as Fanconi syndrome, similar to the constipation lysosomal syndrome that I showed you.
Do you use renal reference range for serum-free light ratio proposed by Hutchison et al. In 2008 in your, the publication of 2008 in your practice?
Sure. You know, if you're looking at the ratio of kappa to lambda light chains in normal individuals, in individuals who are not dialysis dependent, you know, the maximum range is up to about 1.26, and some people carry it up to 1.67. So anything in that range is still within the normal range. Anything that is more than that or is inverted, meaning more lambda than kappa light chain, is obviously abnormal and requires further investigation. Now, remember, when a patient is on dialysis, then you need to take that range and expand it significantly to about 3.17 before you start considering it abnormal. I'm talking about kappa to lambda ratio. You know, I interact with nephrologists and oncologists all the time, and it's very interesting how much information I get at the beginning before I look at the biopsy, how much information I get once the biopsy is interpreted, and that makes it that much more interesting. There are times when the information that I get at the beginning is very, very few words, patient that has an MGUS and has renal damage, and from there we go to a final diagnosis with specific where it is that the damage is occurring, with definite proof that the damage is due to the circulating light chain. And to me, the free kappa to lambda light chain ratio is very important. I had a case like this just today, read it yesterday and called the nephrologist today. A patient with AL amyloid all over. It was in the glomeruli, it was in the interstitium, it was in the vasculature. And when I called her, she said, you know, SPEP is totally normal. UPEP is totally normal. And then my question was, well, did you do the serum free light chain? She said, no, I didn't want to do it now. So again, I think the serum free light chains have added a new dimension to our ability to depict these cases. I should say this nephrologist did not have a clue that this patient had an underlying plasma cell dyscrasia, neither amyloid.
Do you always invert a ratio in lambda disease? And if so, is there a threshold you use?
That's a difficult question. I mean, if you have more lambda than kappa, that's abnormal, period. Is there something that triggers immediate action? I would say every one of them is abnormal. It requires further evaluation. And now, how many of the patients I see with kidney disease have an inverted ratio? I see them mainly in amyloid, and that because the amyloid is a lambda-related disease in the majority of cases. I would say an inverted ratio in renal manifestations, including just mild proteinuria, would make me think about the possibility of a renal biopsy. Now, let me also say that there are patients with MGUS, of course, that I look at their renal biopsies that they don't have MGUS-related disease. I mean, not every patient with an MGUS will have that. I mean, there are patients with all gamma diseases that can occur in any patient who has renal dysfunction. So it's not a guarantee, but I think it deserves further evaluation and further careful evaluation, paying attention not only to the light microscopy, but to the immunofluorescence and the as well as the electron microscopy.
With regards to lambda light chain AL amyloidosis versus kappa, what percent are lambda?
I would say that lambda is the great majority, and if I were to guess, I would say in the 85 to 90% of the cases. Interestingly, the kappa amyloids are the most atypical amyloids. The kappa amyloids are the ones that often present in other organs. By far, the most common situation in the kidney is lambda. Not only lambda, but lambda 6. We have done studies where we have taken mesangial cells. We have incubated them with different light chains of different subtypes, different lambdas and different kappas. And I tell you, almost every lambda 6 was associated with amyloid formation, while very few of the other lambdas and few of the kappas were associated with that. Keep in mind, what we're dealing with here are physical-chemical abnormalities in those light chains that make them interact with that receptor on the mesangial cells in a way that it generates the lysosomal interaction that I mentioned, the transport of the light chain to the mature lysosomal compartment, and the formation of amyloid fibrils in that particular location. And that can only happen when those light chains, most commonly lambda 6, have that particular physical-chemical abnormality that makes them interact with the mesangial cells and makes the mesangial cells do what they do to form the amyloid.
Have you seen cast nephropathy without overt myeloma, for example, in MGUS?
Seen it very rarely. And another point about cast nephropathy that is an important point, and I did mention that point, but I want to reemphasize it. Patients with cast nephropathy sometimes have a very brisk inflammatory reaction as well as the cast. Those patients probably deserve to be treated for the inflammation as well as for the obstructive phenomena that is going on, at the same time that you're trying to control the delivery of light chains to the kidney. But it is rare. It is rare to find myeloma cast nephropathy in the setting that you're mentioning.
With treatment, renal function improves, but only modestly. What are irreversible changes in the kidney in light chain deposition disease?
Usually one of the things that we judge to think of reversibility is how the interstitium looks like. Are we dealing with a very fibrotic interstitium? And keep in mind that the interstitial fibrosis may be due to the light chain deposition disease, but may also be compounded by vascular disease and other diseases that older people have. But there's no question that the more fibrosis you find in the interstitium, the more difficult it's going to be to reverse the damage that has already occurred. The light chains associated with light chain deposition disease are very fibrogenic. In fact, those light chains are usually associated with what we call mesangial sclerosis and the formation of nodules. When those light chains hit the interstitium, they elicit the same fibrogenic reaction, so they're also associated with a lot of fibrosis. So I would say that one thing that would determine more what the prognosis of a given patient in terms of reversibility would be how much damage and fibrosis has actually occurred in the interstitial compartment.
When do you do renal biopsy? Do you biopsy once the SPEP or UPEP is abnormal, or do you consider biopsy if the free light chain ratio is abnormal?
I am not a nephrologist. I am a pathologist. I would love to see biopsies in every patient, but that, of course, is not possible. I think that you have to use your clinical acumen to make that decision. I dare to say again, the patient, of course, has to have some renal manifestation considered to biopsy the kidney. But the alternative would be to look for something in the bone marrow. The problem with looking for something in the bone marrow is that some of these conditions are associated with a very small clone of plasma cells that falls within the quote-unquote normal amount, and people then declare the patient to be free of plasma cell dyscrasia, and that's not necessarily true. I think any alterations of the ratio should be of concern, and an analysis of the entire clinical situation, if the patient has renal dysfunction, could be enough to do a renal biopsy. I think you have to use clinical acumen and decide in every specific case.
Do you consider renal biopsy in a patient who has diagnosis of multiple myeloma and now has nephrotic syndrome?
Absolutely. Multiple myeloma is the beginning of the story. You've got an abnormal clone of plasma cells, and you want to know where the damage is in that kidney. Of course, if the patient has nephrotic syndrome, your thinking is going to be primarily glomerular damage, and that may be the case. You have to consider compounding diseases, like the patient I showed had also diabetes, and the nephrotic syndrome was due to the diabetes and not to the amyloid that was present in the vessels. So you got to take the whole case and sort of make a conclusion on that basis. But I think that indication for a biopsy includes, number one, determining the site where the damage is occurring, and number two, the reversibility of the lesion. And I think it's important to do a renal biopsy in those cases.
Other than the use of creatinine levels, what other routine screening labs give the family practitioner a heads up to look for plasma cell dyscrasias?
Well, of course, the serum creatinine tells you something wrong with the kidney, but you have your serum protein electrophoresis, your urine protein electrophoresis, and your free light chains in the serum. I think your screening today, to be complete, should include the serum-free light chains.
Can you please comment on heavy chains and light chains causing MGUS and amyloidosis?
Well, of course, the light chains cause amyloidosis apparently much more frequently than heavy chains. Having said that, I think we're missing heavy chain amyloid. I told you that in the regular panel of immunofluorescence stains that we use for every renal biopsy, we're going to test for IgG, IgM, IgA, and we're going to look at that critically to see if the amyloid is associated with any of those, and that allows us to pick up some of the heavy chain amyloid. Having said that, I think that we miss many, and that is because, again, the antibodies we have available may not pick up the truncated abnormal heavy chains. It is my understanding that there is a lot of work going on trying to devise a serum test for heavy chains. I think the day that we get that online and we can use it, we'll be able to identify circulating heavy chains much better, and I think that would be the preamble for us to be able to diagnose heavy chain disease in the kidney. As I said in my presentation, the majority of cases with heavy chain-associated disease are going to be located by far in the glomerular compartment. And they come in two flavors, either heavy chain amyloid or heavy chain deposition disease. Heavy chain amyloid being quite rare, but heavy chain deposition disease being seen much more often. Heavy chain deposition disease can come together with light chain deposition disease as one entity. But I think we haven't heard the end to how often the kidney heavy chain related diseases. That's coming.
Is there any significance in strong versus weak monoclonal light chain bands in the urine? Are the stronger bands always indicative of more kidney damage?
In my experience, there is no real correlation. You can have a very faint monoclonal spike of a very nephrotoxic light chain. In other words, it is how nephrotoxic that light chain is what is going to determine what's going to happen in the kidney. It is not how much you have of it, but primarily how. So you can have a very tiny spike like the case I showed you where the spike was so small nobody was willing to call it real, but you could see the damage in the kidney. So I think it's the quality, the nephrotoxicity of the light chain, what would determine how bad and what you would see in the kidney.
Does MGUS only have proximal tubular nephropathy, or can it also cause other manifestations?
No, MGUS can cause any of the manifestations that I discussed today, all the way from glomerular disease and amyloid and deposition diseases to proximal and distal tubular damage. MGUS only tells you that you have a monoclonal gammopathy. You have a circulating monoclonal protein that if it is nephrotoxic, it could be nephrotoxic to any of the renal compartments.
When do you see acute interstitial nephritis with monoclonal gammopathies? Is it only in multiple myeloma?
Well, let's just talk about nomenclature a bit. Interstitial nephritis can be because of many things. You can have drugs associated with it, you can have infection associated with it, and you can have light chains that are deposited on the basolateral side of the tubules, creating the inflammatory reaction that looks like ATIN or acute tubular interstitial nephritis. So the answer to that question is you have an interstitial nephritis associated with MGUS anytime if the light chain is the type that will interact with the proximal tubule and do what I showed, which is elicit the transcytosis and deposition of light chains in the contralateral side of the proximal tubules.
When or at what point do you do renal biopsy in MGUS?
That's a very interesting question. If you have renal dysfunction and you cannot explain it, and the patient has an MGUS, I think I recommend the renal biopsy. Now, one more step. The patient may have another disease like diabetes that could be responsible for the renal dysfunction. However, you know, if you have an MGUS, I think you should biopsy to see if it is the diabetes causing the renal damage or if it is the MGUS or the circulating monoclonal protein. In my opinion, the latter is happening very often today. Very often. We're getting biopsies from patients with MGUS, even though they may have other reasons for having the renal dysfunction that they are experiencing at the time.
Does heavy and light chain always present with nephrotic range proteinuria, or could it be other manifestations?
Absolutely not. You can have even amyloid that presents with very little proteinuria. And I think the case I showed you, remember the case with 500 milligrams a day and the patient had amyloid in the vessels? I would say when amyloid goes to the glomerulus, normally it's associated with proteinuria. Although I had a case last week, amyloid in the glomerulus, very mild proteinuria. So the answer is small amounts of protein could be associated with damage in the various renal compartments, especially if it's tubular interstitial, because tubular interstitial damage and vascular damage will not be associated with significant proteinuria in the majority of the cases.
Thank you very much, Dr. Herrera, and thank you, audience. We are out of time. If you have any questions regarding anything you learned on this webcast or would like to request any additional information, please feel free to contact The Binding Site by email at info@thebindingsite.com. You can also find more information on our website at www.thebindingsite.com. Again, Dr. Herrera, thank you very much for this informative and educational webinar. Thank you, everyone, for listening. The session will now end.